So friends, today I am going to tell you about the treatment RCT, which stands for root canal treatment. So what are the main indications of root canal treatment? Like if we feel pain in teeth, TOP, that is while we tap the tooth with some instrument and it feels pain, that is called as tenderness on percussion. If it is positive, then we need to go for RCT. Then IOPA, that is radiograph saying that the pulp inside the tooth has been affected and it gets radio opaque or radiolucent, then we have to go for the RCT. If the tooth is unable to be filled, then we have to go for RCT, that is root canal treatment. So it is the pulp. If the caries reach this pulp, then we have to drain this and fill it with another material to prevent the dislodged tooth or the tooth becomes non-vital. So steps of RCT includes: number 1 is assess cavity preparation. What is assess cavity? Assess means the way so that we can see the pulp. This is the occlusure of a molar. Now we can't able to see the pulp without opening this area. So assess form is different in all the tooth. It is theoretically different and clinically also different. Theoretically, like in case of incisors, we have to go lingually and made a triangular hole to get the cells into the incisor pulp. But in case of posteriors, we have to include the mesiobuccal, distobuccal and the palatal pulps and made a triangle, or if we include the mesiobuccal pulp, we made a trapezoidal assess. But clinically, we only remove the carious part and save the natural tooth as much as possible, because natural tooth is the much more of strength. So it is the first step of making the assess cavity with the help of an aerator. We only clean and remove the carious part and preserve the natural tooth. Second step is working length determination. That is, the length of a particular pulp is measured. So here we have a mesial or a distal pulp. Example, we measure this till its apical end and measure this till its apical end. It is called an apical foramen, as we all know. So we measure the apical constrictions or the minor diameter so that the pulp is filled or obturate till its end to prevent the infections. So it is determined by the scale, radiographs and non-radiographic methods like tactile sensation. By placing the files or brooches, we can determine the working length, that is a tactile method. But radiographic method is given by different scientists like Inger's method, which tells 0.5 mm short of radiographic length, but it is not clinically acceptable. We go for tactile method in the clinics. We place the file or any paper point in the pulp and determine the constriction. The constriction is felt when the paper point or the file gets constricted in the apical end. Number third step is biomechanical preparation, that is cleaning and shaping of canal. So here is our canal. We place file and broaches in this canal and clean the dead pulp and remove the pulp fibers and make the canal empty and widens it, shapes it like this, we can see, and widens it and empties it so that it can be obturated further. It can be done with files, brooches, and many other things. Then comes the fourth step, that is obturation. Obturation is the filling of the prepared canal. It is done with GP, that is gutta-percha points. So this canal is filled with gutta-percha points. Now I'll tell you the clinically acceptable RCT procedure. The first visit involves the access cavity preparation. Like we remove the carious part and make an access and fill the canal with temporary material and call the patient after 2 to 3 days so that the pulp becomes disinfectant by the temporary and irrigate it. Then second visit includes the working length measure determination and the BMP process by taking IUPAs. So the BMP is done starting from the different sizes of files till end and then again filled with temporary material. And in third visit, if patient is with complaints with no pain and there is no pain to the pulp and the pulp is dried and cleaned and irrigated fully at the second visit, then after removing the temporary, obturation is done with the GP point number as same as the last file used. Like we use the file number 35 while doing BMP at last, then we fill and obturate the canal with GP point number 35. It is done only if the patient is not complaining of pain in the visit. But if patient complains of pain, we have to re-irrigate the canal and BMP is done again till the pain subsides. Then at the fourth visit or on the same visit, we can do post-obturation, that is the crown part of the tooth is made with composite so that it comes in occlusion, and we advise the patient to put a crown, whether it is metal ceramic crown, stainless steel crown or porcelain fused metal crown, so that the tooth strength is maintained. As the tooth becomes non-vital, it can be broken by the masticatory forces, so we advise the patient to put a crown. So it is then ends with the RCT procedure for a person who is having pain approaching the pulp and not in the dentine. If pulp and still the periapical area or the periapical pain ends with the endo. This is called an endoperio lesions. We will discuss these lesions in the next video.